Good afternoon, everyone. I'm just watching participants start to filter in, so we will begin shortly. In the meantime, if you'd like to join our mailing list and receive news every couple of weeks about upcoming events that we have, including other webinars in this series, the QR code on the screen will take you to that short form. All right, it looks like we have the numbers have stopped coming up. So just wanted to thank you all for joining us today and to let you know that we've got a QR code here on the screen if you'd like to get notifications about upcoming webinars in this series. And also wanted to cue you that the chat and Q&A functions, you can use those as you're listening to the webinar to, if you'd like to ask any questions, to queue up any questions for the Q&A at the end. I'm going to turn things over to the Executive Director of Big Cities Health Coalition, Chrissy Giuliano.
Thanks, Elizabeth, and thanks everyone for being here. It's fun to see some friends in the names in the chat there. So thank you to friends new and old. We're excited to discuss with you today our vision for the future of public health and urban public health in particular, and to share some real world experiences from our members. We'll be making the slides and the recording from the webinar available on our website, so look for an email following the webinar. So again, I'm Chrissy Giuliano, Executive Director of the Big Cities Health Coalition, and joining me today is Dr. Anneta Arno, who's the Director of the Office of Health Equity at DC Health here in Washington, DC. So I'm going to tell you a little bit about the Big Cities Health Coalition, then a little bit about the Urban Health Agenda, and then I'll turn it over to Anneta to talk about what they're actually doing on the ground in DC. So BCHC was started 20 years ago as a way to convene leaders of the country's largest metropolitan health departments on the premise that there was something unique and different about big city health departments and being a big city health commissioner. Over that time, we've grown to 35 members who together serve about 20% of the nation's population. And you can see our member cities on the map here. Our work together still focuses on the common goals that we were founded on, which are namely sharing best practices, strategizing around complex urban health challenges, and advocating for urban health, health equity and racial justice, and the governmental public health field as a whole. The purpose of the webinar series, and today is the first in a series of 3, is to introduce our urban health agenda and show what its core ideas look like in practice in our member cities across the country. So we'll discuss a few key concepts today, but if you'd like to learn more, please do visit the website, as you can see on the slide. And we have another fancy QR code. The image will show you where to find the document, and again, you can scan the code. So the Big Cities Health Coalition Urban Health Agenda really rests on the idea that protecting and promoting the public's health is more than healthcare, and even more than what we traditionally think of as health. So to truly achieve healthy, safe, resilient communities, we need things like full employment, livable wages, and earned sick leave. We need safe, affordable housing in neighborhoods that have access to healthy foods and safe public transportation, and safe, appropriate K-12 education, and parks and green spaces for people to be able to be active in. This comprehensive cross-sector approach can only be effective if we also work to dismantle structural barriers and systems that are built on generations of racism. Inequity is driven by many isms, including racism and classism and many more, and they really contribute to systemic oppression in the form of laws, practices, and other norms that lead to negative outcomes. For example, in the US, owning a home is one of the best ways to build wealth, but people of color have traditionally been shut out by policies such as redlining, which excluded them from ownership and thus cut off decades of wealth building among Black families in particular. Economic opportunities and quality education are also out of reach for too many people, which is perpetuated by fundamental barriers that widen wealth and health gaps. Political power is also not equally distributed, and communities without such power may struggle to be appropriately served by government. And as we continue to see, barriers to voting can make things even worse. In our vision, all government agencies and relevant community-based organizations work together to promote and protect the health and safety of their communities. Public health departments can and often should sit at the center of decision-making processes across all government agencies. Health commissioners and other health leaders in big cities in particular sit in a mayor's cabinet, which can often present a unique opportunity to influence citywide policy in ways that some in other jurisdictions may not. And that's true also in DC. So while health departments play an important role in protecting and promoting the health of communities, no single government agency or government alone can improve urban health. To be successful, these efforts require collaboration across government agencies with elected and appointed officials and community-based partners. How this all comes together really sets the stage for today's speaker, Dr. Arno. To get at the root causes of health inequities, we cannot rely just on healthcare or health departments. We have to work again across agencies and organizations and with community in authentic ways to create structural change. So today we'll focus on collaboration across local government agencies, and we'll see how the health of communities can become even stronger when agencies such as transportation, housing, utilities, school districts, and others can work hand in hand. So with that, I want to introduce again Dr. Anneta Arno, who's the Director of the Office of Health Equity at DC Health. Dr. Arno has an amazing track record in the field of health equity. She's worked at the City of Kansas City Health Department, also in Louisville, and has been in DC for many years now. So Dr. Arno, I will turn it over to you.
Thank you so much, Chrissy. And I will share my screen. I think we're here. And let me go to presentation mode. I think I've got. Okay, hopefully everybody can see my presentation. Great. So thank you so much, Big Cities, for having me on the panel and to kick off this series. I was also thrilled to have participated on your launch day when you launched the Urban Health Agenda. And I think I think Chrissy covered it really well, but I think the real issue, what I see from the Urban Health Agenda, is the idea that we center equity in public health, and we center public health in all citywide decision-making. I do know too that, as Chrissy said too, everybody's in a different situation. So you have to cut your cloth to your particular situation. So what I'm saying is not what will work everywhere. I've worked in 3 different health departments, as was pointed out, and the circumstance, the context, how the public health department is situated is slightly different, but you can still work towards getting similar things done. And sometimes it's faster and slower. But what I like to say more than anything else is that health equity is patient work. It's everybody's work, but it has to be patient. So I'm going to start off with just talking about DC Health and the fact that we have this mission overall that talks about promoting the health and wellness and equity across the district. Our vision is to be the healthiest city in America. We also have some guiding principles that everybody in the department has to work towards, and that is servant leadership, transparency, I won't read everything, strategic thinking, creativity, and innovation, but that health equity needs to apply to all that we do. And then if you think about it, we are in the nation's capital, we are a regulator, but we also need to make sure that we are not only talking the talk, but we walk the walk, by being a role model, a convener, and a collaborator. And that's really, these kinds of roles can really shift depending on your context. So context counts for your public health agency. Our 5 strategic priorities are to promote a culture of health and wellness, to address the social determinants of health, and I want to underscore that. That's not only my job as the director of the Office for Health Equity, it's everybody at DC Health's job. Strengthen public-private partnerships, close the chasm between clinical medicine and public health, and to implement data-driven, outcome-oriented approaches to program and policy development. You've probably all seen this. We've been working in DC Health and before on equity, but it was pleasant. It was a pleasant surprise. And I guess there's nothing like the crisis of the pandemic to focus people's thinking. But we also have seen a rethinking and centering of equity in the 10 essential services. So I put that up there, so it's not unique. Everybody has the opportunity to kind of say, hey, look, equity is supposed to be center of all of our work. So if we think about the Office for Health Equity, we have a mission that is slightly kind of more embellished than the one that's for the Department of Health. We have a theory of change, which I've summarized in 3 bullet points: as a learning organization, as the need for us to change the narrative, and then ultimately to change the practice. So we are a think, do, tank. So we're not just talking, we're not just doing data, we got to do some stuff to demonstrate practice change. With that, and so I'm going to go really fast, but this is more because, and I'm happy to share in a PDF all of the slides, but it's more to make sure that there are pictures to kind of communicate my fast message. Our mission is to address the root causes of health disparities beyond healthcare and health behaviors. And that's by supporting projects and policies and really facilitating multi-sector partnerships and collaborations. And this mission was actually designed by Dr. LaQuandra Nesbitt, who is our immediate past director and was a well-known and is a well-known member of the Big Cities Health Coalition. But in many respects, we built it on the learning of some of our collective experience in Louisville, Kentucky, in the original version of the first Center for Health Equity in the country. So I kind of moved forward from that. So very quickly, I'm going to tell you what I'm going to tell you, and then I'm going to tell you again what I'm going to do. So changing the narrative means what I've been doing since I've been here. In 2016, we had the Buzzard Point report. We called it the Community Health and Safety Study. It was not a traditional health impact assessment, and that was deliberate. It has some kind of nuances. We also did a Safer, Stronger DC report, which was about a public health approach to violence prevention. We also launched a program that we continue every summer called the Healing Futures Fellowship, where we basically bring young people to the conversation from all across the district to really talk about injury and violence prevention as a public health issue, but also to engage them in a narrative about equity, to make that a lifelong part of their learning experience, whatever they decide to do when they grow up. We launched the Commission on Health Equity. It was a remodel from the original draft legislation that talked about the Health Disparities Commission to one that's more functional to 21st century public health. And then kind of the big thing that we delivered, and I think this was a real, a real important point. We published our Health Equity Report 2018 in February 2019. So that's kind of the jumping off point for changing the narrative. We did some stuff, we did data, but we also had to show, and there was learning that I learned from Buzzard Point, Safer, Stronger, Healing Futures, and the Commission's work that informed even what ended up in the Health Equity Report. Here we are now. I like to think of it as being, OHE is in bloom, and we're changing practice. We've got the Commission on Health Equity still in existence. We're doing something on roadway injury surveillance. We're doing health equity impact review. We're doing a health opportunity index, which is somewhat of the next iteration of the Health Equity Report, where we're going to integrate the data a lot more. We're talking about a health literacy strategy for the district. We're talking about, we had a health equity summit in 2021, which we actually did bring together all of the 9 key drivers that I'm going to talk about. So this is kind of showing you where the work has gone. And then I'm going to really start a little bit more with the Calling All Sectors initiative, which which we started back in 2019. And then ultimately, I'm going to talk a little bit about Lead-Free DC 2030. So changing the narrative, what I talked about was this, what I call the 9 key drivers, which in some respects you can see from this report, where we have these 9 things, and you'll see what they are: education, employment, income, housing, transportation, food, medical care, outdoor environment, and community safety. So in 2019, not only did we publish this report, but Dr. Nesbitt also declared the framework that DC Health would be moving forward in its health equity framework was this 9 key driver framework. And so we started doing this, and I'm gonna kind of pull apart some of the health equity report and the knowledge that we put together to really demonstrate that we were not just making this stuff up. It was data-driven and evidence-based. So we had these things that we called, you know, we knew about the county health rankings, but more importantly, we started talking about the social and the structural determinants of health, which in some respects was somewhat new. We talked, the donut, as we show people, all of this is in the health equity report. And I'm just going to click down and talk about these things. Health is more than healthcare. Health inequities are neither natural nor inevitable. Zip codes more important than your genetic code for health. The choices we make are shaped by the choices we have. Structural racism acts as a force in the distribution of opportunities for health, and the notion that all policy is health policy. I think what we did in this report was make things that prior to was implicit much more explicit. So we named the racism and structural racism as a thing. We demonstrated that we have one of the most segregated cities in America, as great as DC is. So there's a lot of truth telling that needs to happen, right? DC is a great place to live, but we've got some issues that we can't keep telling ourselves that, you know, we're better than everybody else. And we are, I'm not saying we're not, but we have to do the truth telling to the folks here. And sometimes it's hard to embrace that language. We also showed that there was a 21-year difference in life expectancy at birth by drilling down to a really granular level to 51 statistical neighborhoods and not just the wards that we've traditionally talked about, to show that we could actually demonstrate that this was true. We mapped each of the 9 key drivers to those 51 statistical neighborhoods and showed the data. The dots on the map show the correlation between health outcomes, gross rent, and life expectancy. We showed the same data in relation to education. We did it for income. I'm not going to show you all of them, but I'm just showing you that we mapped them all. We can continue to map. There were multiple maps. And we could show that even though we had the highest rate of health insurance in the country, we still had disparate income, and we could show that there was a difference in outcome by income and race, and even by gender in the district. You can go and Google the health equity report for the District of Columbia. The big report is 250 pages long, deliberately, because we didn't want to have a report on the street that folks kept coming back and asking us, but you didn't look at this, you didn't look at that. These two kind of graphs here are really showing you, or tables are really showing what I call the health equity bingo. At the top of the list, you show that everybody at the top has the green is showing some of the best outcomes. So it's almost bingo, bingo, bingo. On the right-hand side, at the bottom of the list, we have the least good outcomes. We color them red and we see the similar kind of bingo, bingo, bingo. And in between, you're seeing a spattering of green and a spattering of red. Ultimately, what this is actually showing is not just this dichotomy between rich and poor in terms of health outcomes and life expectancy itself, the quantity of life, but there is a small increment all the way down across the 51 statistical neighborhoods. And so ultimately what this is telling you is not only that these things are happening individually, but they are interrelated pathways where they are working together to cause these inequitable outcomes and to recreate them day in, day out, no matter what we think. We've done all this good work in one sphere of business or one sphere of the economy, but we're still getting poor outcomes. We don't have the luxury ultimately to choose one above the other. We have to do it all. And that's why I say health equity is everybody's work, because there's enough work for all of us to get busy. But what is critical is that we're all focused on moving in the right direction. So what we're seeing is income, place, and races are driving health outcomes in the district. So having published the report, we now needed to start doing things. And so one of the first projects we worked on was called the CASI Project, Calling All Sectors Initiative, funded by the Pew Charitable Trust. But what you can see here on the left-hand side is that I'm showing you that we're really connecting housing and health for this particular project. What we did specifically was to work on the intersection of homelessness and maternal and health care, right? So pregnancy. What that required us to do was to bring together folks in all of these areas, right? So we've got DC Health, of course, but we have the Department of Human Services, the Housing Authority, Housing and Community Development, Thrive by 5, and the Interagency Council on the Homeless. And we also engaged a community-based organization. And it required what we call collaborative actions for change. We didn't come into it, and so this is the other thing that we all have to learn. We may be in public health, or we may know all of this, but it's not just the fact that we know it. We have to go with our community partners with some humility. Yes, we've got some knowledge and we bring some insights to the table, but we don't know it all. So we need to think about what we do and what we learn. So this is kind of giving you a very quick rundown of what we did. So we did data sharing between the agency, but collaborative learning. We had to learn what their challenges are and how they see the world versus how we see it. We talked about data gaps, and one of the first things that happened was to try to address a data gap. And because we didn't go in there with our fingers pointed at them and more for a collaborative process, within, I would say, 3 months of us starting and launching this project, they started collecting some critical data that really was strategic in moving the needle along the way. What we ended up getting was a major policy shift for the city. They didn't necessarily change the regulation, which has been in place for a long time. Sorry, they didn't change the law, but they were able to change the practice, and they were able to change the way they apply their regulation. And most importantly of all, the new policy ensured that the city was now serving pregnant residents in their first and second trimesters, and that we were started to collect data for the first time to know how many people were being turned away, therefore to even measure what the need was, etc. What we learned too was that we could close the gap by collecting data, and we made recommendations for sustainability. So even though the project was funded and the project is now ended, we've got these things that our partners who played with us in this particular project are able to follow through with along the way, right? So we don't always have to be there all the time, but we can have an influence in what our partners are going to do. And they've all expressed appreciation for how important that was. And it included the need for training their personnel, the need to promote an equity across all the systems that we develop. We have developed a systems map, so we better understood how the different agencies come together. And we also are developing a framework for community engagement, for collaborative practice across the board. So we haven't published these documents yet. As I said, we finished the project, but we are expecting in January, the coming soon part is we have an evaluation report that we've hired some consultant external evaluators to kind of take a look at that and to have a framework report that I'd be happy to share. But it talks about these 6 steps: engaging core partners, construct a program, developing evaluation criteria, implementing measures that we will collectively work towards, formulate conclusions, and to share findings and plan for the future. So think about sustainability and do things that, you may not know where they would end up. And I have to be honest with you, I did not necessarily expect that we would get the practice change that we got, but it actually did happen in some respects faster and sooner than I thought. And I do think it was our approach, the strategic approach of working with them collaboratively and going to sit with them and sit in their space and understanding what their challenges were that was really important. I'm going to click a little bit faster. So this is something that we did during the pandemic. Really, again, what I'm really trying to demonstrate is how important this 9 key driver framework that's sitting at the center that you've seen before has been in all of our work since February 2019. So we could actually look at this 9 key driver framework, and we could see during the pandemic what they were: differential access to supports for learning, and how all of that, the mayor actually developed a reopen DC process, which was loosely based on these 9 key drivers, right? We had 11 committees, 9 of them kind of looked almost like this. Then there was an equity committee as well. So we looked at all of these things and really thought them through. We were also, in parallel with those committees, we started thinking about differential impacts and what are the things that are driving the differential outcomes that we were seeing. And so we put together what we call the Structural Vulnerability Index. On the right here, you can see what we did in the pandemic. In fact, the district as a whole started publishing the data in terms of infections, vaccinations, et cetera, to this 51 statistical neighborhood kind of look. And you can see that we were able to track, for example, the first phase of the pandemic went along the 14th Street corridor. Then we saw it shifting towards the east of the city and Ward 5 and towards, we moved from an area where it was mostly focused on the Hispanic population through to folks who are more immigrant populations, and then it's now settled in a little bit more in Ward 7 and Ward 8. But we've also seen differential outcomes for what people typically expect. This is ultimately what happened. COVID became the third leading cause of death in the city, but all of the indicators got appreciably worse. As a result, we also got a grant to do some health literacy in the district, and we're applying the same kind of lens to try to drill down in a more granular way to work with specific populations across the city to address those issues. So we're going to look now at interagency learning, and now I'm going to talk a little bit about what we did with lead and what we're still doing, so it's not over. So if you ask the question, who is responsible for addressing lead in water in the District of Columbia? I've given you the answer, right? It says DC Water, the US Corps of Engineers, the Department of Energy and Environment, Department of General Services, the Environmental Protection Agency, and the CDC. Nowhere on that official list do you see DC Health. However, and we don't see it, but because in our book and in our view, health equity is everybody's work, we see that we have a role to play. And in fact, we were lucky in the sense that because of our health equity report and because we have kind of put out this idea that health equity is everybody's work, we actually got approached by DC Water to engage with them in the process, right? So they launched this report in 2021, June 2021, that talked about they were about to make some major investments in repairing lead pipes in the city in the public realm. But they also recognized that there was an important opportunity for them to take an equity approach to the work that they were going to do. So I've kind of blown up on the right-hand side what's actually written in that paragraph. And really what it talks about is this approach prioritizes that lead replacement should start in places where vulnerable populations are most impacted by lead exposure. So they talked about children and seniors. And then they talked about communities that are historically underserved and experience disproportionately poor health outcomes compared to other parts of the city. So you can see that that aligns very well with the work that we've done and talking about the work that everybody has to do in the city. Now, as I said, yes, everybody can agree to what has to be done. It's not always immediately obvious what the solution is going to be, or do you know right off the top from what I told you what we actually need to do together. And what I'm showing you here is before they really started working with us, they had already started doing baseline data of their own. And you can see on the left-hand side, they show the density of kids in the city. And as you can see, the density of kids in the city, it's dense in different parts of the city and as dense in some parts of the city more than others. But if you balance that with the second slide, which talks about the most disadvantaged block groups in the city, you see that it's very much concentrated in some parts of our city and not in others. So up in the Northeast, we can see that they're the least advantaged folks in our city. And then down at the bottom of the map, the other map, you can see the red areas and then some others where we have the most disadvantage. So if you're going to think about, if you're going to start with the children and families and seniors that are most disadvantaged, it suggests that it should start down in this part of the city, but it also lets you know that there's some other parts of the city that we can also take into account. And similarly, when I showed you the map about what was happening in COVID, you can see that there's some parallels in the data in these maps here. So ultimately, what we've been doing with them, and I don't want to say we just started, but it's still a lot of work. What we are working on right now is pulling together what does the data look like for the health of women. So we've got a lot of data on the health of women, the health of children, the health of seniors. We have a process in the district called Living Well DC and all of the other things that we're trying to do. So this gives you a kind of a starting point, and we haven't finished this project. This project, as you saw before, it goes on until 2030, but this gives you a sense of the kinds of things that we are going to be working on and how we are going to approach our relationship with DC Water. And so I'll move to the next one, which DC Water was also a part of. And so this is about a year ago, we started doing some work about how do we sustain our work and grow and demonstrate how interagency collaboration has been actually functioning in the district. In May 2021, we actually published this, what we called it the post-pandemic report. We're a little bit ahead of ourselves, as they say, you get ahead of your skis. We thought the pandemic was nearly over, but clearly it wasn't. But one of the things that we also published at the end of nearly that year, Dr. Nesbitt published the report in the Public Health Journal of Practice, really talking about what I've now labeled the three-legged stool. The idea that this report really focused on the healthcare part of the house. And there were two important and crucial legs that needed to be addressed. So the social and structural determinants of health, which is what we've been doing in the Office for Health Equity, but also structural and institutional racism. So I've been doing some of that work, but the good news is, so the focus of the focus of the summit was on these two other legs that we hadn't worked on before. I did say earlier that we've been doing the truth telling and we talked about structural racism, but in just over a year ago, the mayor also launched the Office of Racial Equity and appointed a chief equity officer. And so I've been working very closely with Dr. Amber Hewitt in doing that work, because what it means is that we get both of those things pushing together. It's nice for us to collaborate, but it also means that we have our related lanes, but not necessarily tripping over each other and doing the work together and collectively. So after that summit, we developed our summary report, which came out in July. And really what we know is that during the pandemic, we learned a lot. We learned that it takes the whole of the community. So health equity clearly is everybody's work. We need to promote and continue to promote this culture of wellness and DC hope, which is health, opportunity, prosperity, and equity. We need to repair the past to transform the future. This one and the next one is really about engaging with community and thinking about racial equity as not just the thing that this is kind of behind the scenes, but we need to proactively acknowledge it. But these last two also is to ensuring that we are moving towards policy change. We're not just sitting on the sidelines. So as I said, we're a plan, do, think, and act kind of agency. We need to change the policy and change the practice and then organize ourselves for change. Just so you understand, this is a summary of the recommendations, and I know you can't see it, but I'll be happy to share with Chrissy et al. The links to our reports and how you could get to them. But they're the 6 main buckets that I talked about, and what we learned, the takeaway and themes from the pandemic, and what the insights that kind of generated that. And then we could look at this one. I'm going to kind of unpack this a little bit, leveraging policy and practice change momentum. So we know that innovation was the hallmark of the pandemic. We know that we can change because we did a lot of things during the pandemic that people thought we could never do, like telemedicine and et cetera, et cetera. We need to advance equity, and budget is really important. So even as we have started our health opportunity index, we know, for example, that in Virginia, they've been using the HOI to inform their budgetary process. We've also introduced in the city a racial equity impact approach to thinking about the budget in the city. So all of these things are coming together. The actions that we need to do is to maintain this action-oriented can-do posture, not say, okay, the pandemic is over. We don't want to go back to what the pandemic, before the pandemic. And we need to take evidence-based and evidence-informed risks, but learn from them and turn on a dime in the same way as we try to make these things happen. Anticipate potential adverse impacts. So that's why we're doing things like health equity impact assessments or racial equity impact assessments for my other colleagues, and to try to make sure we understand this. And then the other thing that we are currently doing, we thought we would have been further along on this, is leveraging the local healthy people strategic planning process for sustainable ends. What we did when we launched this in May 2022 was to think about equity as a central tenet, to explicitly name and employ an anti-racist lens, and to leverage this whole of community response to drive practice change in a multi-sectoral health and all policies, 9 key drivers framework that I'm showing down here. So we've got all of those things happening. We're using a process that we had before, but we're now about to augment that moving forward with this idea that anchoring collaborative actions and impact means that we need to think about sustainability long-term. While we've been very successful in Healthy People 2020, our 2030 process is adding this new steering committee that will have representation across all of the 9 key drivers so that they on a regular basis come together. So it's not a happenstance that folks hear about health equity and what their contribution to the health of the district is, but they're actually sitting at the table as the district as a whole talks about health and talks about health and public health in a very holistic way. So I had a very good conversation with the deputy mayor just yesterday. We're a little bit behind. We did plan to launch it in December. I'm still hopeful, but although I think we were going to do a kind of just an informal launch in December and really start in January, but we are really at the point where this is the work that is about to happen of really making this sustainable for the next 10 years. And so here's a summary of what we're doing in terms of bottom line, that health equity needs optimal health for all. And we're really thinking about the whole health ecosystem. And in that, we're talking about the 9 key drivers. That's what we mean by the health ecosystem. It's not just healthcare or public health. We need to do those 3 things that we talked about in the post-pandemic stool. And then just for to quickly talk about this is what came out in the post-pandemic report, and then the other thing. So this really is how we are doing multi-sector collaboration in DC and kind of bringing all of those things. And I have to say, I may have had this idea. Some of the things that we did in Louisville didn't necessarily work here. Some of the things that we may have tried to do in Kansas City didn't necessarily work here, or they will work, but they don't work in the same timeline. So that is really what I'm saying. What we really need to think about is start where you are. Think about, and I think I've said this before, start with the few partners that you may have, which we might call the coalition of the willing, so to speak, right? Because when we did our Health Equity Summit, we realized that we had and I'm just going to show you this one. We knew this had happened. We have a housing equity report in the district that came out in 2019, right after we have a urban planning, our new plan for the District of Columbia, comprehensive plan has an equity lens. So there were some early adopters. Then you'll have what we call the coalition of the curious, some folks that came together. So in some respects, our Health Equity Summit was a coalition of the curious. And what we're looking towards in terms of the Healthy DC 2030 steering committee is basically what we would call the coalition of the necessary. So we go from people getting comfortable with the idea that equity is everybody's work. We do the truth telling so that people are not telling each other half truths, right? So even if you have a criticism of one of your, or what you think is a criticism, what you may not know is they probably have a good reason or a law or something that prevents them from doing what you think is absolutely easy to do. And sitting with them, sitting in their shoes, working with them. And it could be that you're starting where you're saying, this is not the absolute best solution, but it might be the floor and not the ceiling. But you get them to the floor and then you keep giving them an internal nudge to get to the ceiling. What I know from my past experience in other communities as well as here is sometimes people get the push and then they'll use you, doctor, they'll even say, Department of Health says we need to do this. You don't go in saying the Department of Health is pointing fingers at them and telling them they are the problem. You need to understand, you need to sit in the room, sit in their space, sit in their challenges, and learn from them what their challenges are and be supportive in getting them to maybe the ground floor. And even if you have to stay longer to push them along to get to the ceiling. And if it's not the ceiling, it's at the dado rail or something else where you're going up and up and up. And so I really have to say to you that even in our work with on the BCHC project, Calling All Sectors Initiative. We went into that purely with the idea that we needed to sit in the space of thinking about what happens at the intersection of homelessness and maternal health. We had set a goal of having 100 units, or 100 spaces, or 100 slots, again, informed by pre-collaboration with our partners and not making up stuff that was wholly unrealistic. And then we ended up with a space where they've actually started collecting the data and putting those things on the table. And I expect a similar set of outcomes when it comes to lead in water in the district. So with that, that's my last slide. And here's how you would be able to connect with us in DC Health. And with that, I am going to stop sharing. And I hope I did that. And I know it's a lot. We're happy to share the slides in PDF format, but it's really to kind of talk about the fact that there's no one thing. There's no simple process, you know, even if I say the coalition of the willing, the coalition of the curious, but who are those people? Some people join, they leave, they come back, etc. So that's it from me. Thank you.
Thank you very much. And we do have a question queued up, but I just want to let everybody know that this is really intended to be a very sort of practical webinar for you to have a chance to ask questions of someone who's sort of been through this process, and to kind of share your own experiences and maybe ask for some reflection and advice. So, you know, please do go ahead and put your questions either into the chat or preferably into the Q&A box. And if you would, please include your affiliation when you send in your questions, just so we know kind of what perspective you're asking from. So the first question that we've got for you, I think, is directed to Dr. Arno. Is from Thomas Plant at Boston Public Health Commission, who's asking, was DC Health able to access federal funds to reduce the lead service lines in the most vulnerable neighborhoods in DC?
Well, one of the things I noted was DC Health doesn't have a formal role in the lead pipe conversation. So the people who are getting the funding is DC Water. So they're the lead federal agency. They're the ones who are responsible for that. What we are collaborating partners with them. So we don't only play in games where we are the lead partner, right? We play in games where we are a good partner, a good collaborator, where we are bringing the data and we're bringing the conversation and the insight. So no, we didn't get any dollars. What we do expect to happen, however, is we're working with them and we may get a fellow. So the fellowship process has been something that we really, in fact, I didn't talk about that during my presentation. When we did the Calling All Sectors initiative, we got a very small amount of money, all things considered, right? And I decided it wasn't enough to change all of those systems, but it was enough to hire a fellow who would focus on the work that we required to do in what you would call herding the cats with the collaborating partners, going with them and sitting with them and figuring out the data, etc. And I think we got from the Pew Charitable Trust to Health Impact Project, we got like $150,000 to do that work. And out of that $150,000, we were required to give at least $30,000 to community-based organization. What you have to do is be very strategic in who you select as your partner. We did not select a very small CBO, and that was not because we don't think small CBOs can actually do this work, but $30,000 is not a lot of money. And what we needed was to give it to somebody who could just put it there and sit with us and be our thought partner. So in fact, we are frequently thought partners with other partners, and we might actually engage another thought partner who will bring some additional insight. And what Community of Hope, who I showed them on a different side of the house from the government partners. They are on the ground. They're one of the few community organizations in the city that does both maternal health and homelessness. So they were able to inform the narrative. They did work with their partners, so other community-based organizations, and they did not need the $30,000 to keep their organization afloat. So we could actually come to agreement with them as to what that work needed to look like. And what we ended up investing, or I should say they invested in collaboration with us, was to do some work that we funded a couple of researchers at Georgetown University to talk with folks who had the lived experience of some of that work. So if you hear from Dr. Nesbitt, she'll frequently tell you it's not about the money, and it really isn't. And sometimes it is, but frequently it's not. It's about working with partners in helpful collaborations. When you're not doing finger pointing, you're doing more collaborative learning. So you see that I showed you that as part of the two things we're publishing, which are the evaluation report and what that framework, that learning framework is, the collaborative learning with partners, and sitting in their shoes and some of their barriers. And then you start, I call it useful infection. You start infecting their brains with the idea that they could do something differently. That's the best kind of infection, right? Not, and so, or maybe maybe the better word would be, how do you immunize them against some of the poor thought processes that they may have had before, where we can't do it? Well, I'm not coming in and saying you can't do it, but I'm saying let's at least try. And so we're doing the same thing with DC Water. They have got quite a bit of funding from the infrastructure laws that and resources that have come about, but we have not asked for a share. I think sometimes if you go in there only asking for money, it feels like we're not necessarily going in there with the right kind of partner idea in mind. But I always speak up. So anybody who is listening, if there are any funders on the call, what I would really love to have is $1 million where I could fund $1 million per year, that is. I could fund each of my 9 key drivers with one fellow and then somebody to coordinate all the 9 key drivers. Think of what that brain trust would look like if we were able to work with each of the sectors. And I'm not giving up on that. I may actually get some of those sectors to pay for it. But I've demonstrated that as a very functioning and successful approach. So that is something that you may want to think about, having somebody, and sometimes it needs to be a very small project. If you get too ambitious and the other thing that I like to do is under promise and over deliver, right? Don't go out saying we're going to change the world when maybe what you're going to do is do something that will contribute to changing the world. But I think the idea of practice change is really my goal, as I showed you before. So first you change the narrative, then you change the practice. And the practice that I'm talking about is not only in public health, it's practice change all across those 9 key drivers. All of those folks have been trained in their particular industry that has particular precepts that has given us the inequities that we see outside of public health. And so they are the ones that we have got to encourage with practice change and thinking about doing things differently and better. And in fact, I just had our acting director of planning, our new acting director of planning, came to me and said, I want to do some work about trauma-informed planning. I'm like, whoa, fabulous. I don't know what that is, but I'm with you, right? So so my point is that you've got to infect and change their thinking as an important part of it, and not come in with finger pointing kinds of approaches.
Mm-hmm. Great, thank you. So I've got one comment, one prompt, and one question. Mm-hmm. So one at a time. The comment is from Colleen Harmon from Chicago Park District in the chat. She says that Chicago needs this and to prioritize health as a structure. Thank you. The prompt is to the audience. I noticed that we obviously have a lot of folks from public health departments here, but we also have some folks from city and county department or offices that are not public health. And so, I'd love to hear from you about what drew you to the webinar and what kind of collaborations you're thinking about with public health. The question that we've got is from Michelle Sanders from, I believe, Illinois Public Health Association, who says, what type of outreach was used and did you use community health workers?
So we have not, let me just say that the Office for Health Equity, our focus, we are not what I call a traditional health department, right? Most of my focus, because of the 9 key drivers, outside of DC Health. So it's all the other partners. Community health workers, we have been doing, I know for a fact that Dr. Nesbitt has worked a whole lot on trying to put that as a training that we are doing in terms of ensuring that we could actually have some certified community health workers. So we did not start with community health workers, but I'm not saying we're not going to use them. And so they are used in other parts of the department. When we published our first health equity report, we took the report and took it to community to hear their feedback in all parts of the district. In fact, who we partnered with for that was to really do that with the Commission on Health Equity. And I see somebody says something about HIV. Our HOSTA, which is an administration here at DC Health, has used community health workers quite a lot, right? So we have, and I didn't get into that, we have 6 administrations. Office for Health Equity is the youngest and the smallest of 6. I work with all of them. I kind of feed them some of the ideas about health equity. And in fact, I stole one of their best people, and she's now working with me as she's heading up our health literacy work. But it's something that we are all doing all the time. And I think, and I have to say, we all have a lot to learn. We still continue to have to learn it. There's a lot of work. They're changing the practice in terms of community health workers. The mayor convened a healthcare workforce kind of commission, that is doing some work because of the severe healthcare shortage that we have. And then internal to DC Health, we've also started a public health workforce working group. And so community health workers are an important part of that. As we think about it, I'm overseeing the recruitment part of what that looks like and ensuring that we have equity, diversity, inclusion, and justice is part of our framework, but also how do we put in place some of those fellowships. So my fellowship model is now kind of coming into its own about one of the ways that we could do this, and having folks trained to do some of the work that we frequently find as hard to fill in our city. So I haven't necessarily talked about it in terms of community health workers, but I think it's an important part of it. I did not start by saying DC Health is a little bit unusual in the sense that we are not a traditional health department. We do a lot more in the what we call being the chief health strategist for the district. So our HOSTA department, who does the communicable disease, etc., they do much more in what I would call traditional public health department work because of the nature of that work. The rest of us are doing much more strategic efforts, etc. There is an important role for community health workers. I'm trying right now to develop our community engagement effort that really kind of will be an important part of how we do our work to ensure that folks understand this. And I think it's an important part of, if we are to move the needle on health literacy, what that needs to look like, and how do organizations, and those are the ones who, the organizational health literacy is the new part of health literacy, the health literacy conversation. How do we bring that? How do we bring that to scale? How do you operationalize that? And we're actually working with a series of 6 CBOs who are basically working, they're closer to the community, and we selected them to ensure that they were connected to the Hispanic population, to the immigrant populations, and to the African-American population in the pockets of the city where we know we have some significant work to do despite our success with COVID. So it's a yes and no answer. How I've rolled out my work, it's now getting to the point of practice more than anything else.
Thank you. Our next question actually came in anonymously, but it's, how did you move towards more of a strategy / thought leader role initially?
Well, I have to say that some of this comes with the learning that I have done in my past roles, right? When the Center for Health Equity, great as it was in Louisville, Kentucky, was launched, it was at the very beginning of the conversations about health equity. And I think at that point, the focus was transitioning from health disparities to health equity, but there was still a tendency to be very focused on embedding in communities that were disenfranchised. And there's nothing wrong with that. I think that is important for traditional public health and other folks who are delivering services to do. But if you're going to change the narrative, it's the other folks that really need to understand that they may have to give something up if they want to see something different. So many of you will have seen what is the difference between equality and equity with the 3 boxes versus somebody without a box, some with 2 and some with 1. In fact, that was the pivot that Dr. Nesbitt and I started in Louisville about starting the conversation about health equity is everybody's work, first and foremost, and then really demonstrating that everybody has to be in part of the conversation. You can't just assume that there will be some kind of trickle down because that's not worked, or you're going to be silent about racism or any of those things. You have to be proactive and pointed and saying that some people have to give some stuff up. That's really the critical part of it. And that's really where, even as and you asked the question about a thought leader, that's why we went to one CBO organization who we knew would have the luxury, and I have to call it that, the luxury of being able to sit down with us on an ongoing basis and talk about what the challenges are before we came up with solutions, even and also going into something that was pretty vague and not knowing where we would end up collectively.
Thank you. I think that was, those were our questions. And in fact, it's perfect timing. I think we're ready for, for the last slide, which has our kind of closing information, Walker. Great, thank you. Handing over to you, Chrissy.
Thanks so much. I want to thank Dr. Arno for spending time with us today. Always fun to hear you talk about all the things you have going on in DC. So thank you for sharing that. Also want to acknowledge our funders on the urban health agenda work, sort of across the board, supporting all of BCHC's work. We look forward to having everyone on the next 2, at least planned in this series. Please do join us if you can, and do feel free to follow up with us if you have questions or thoughts or ways that we can connect with you all on the urban health agenda. Was I supposed to say anything else, Elizabeth? There it is. That's how you can reach us. Thank you all for your time today. Appreciate it.
Thank you. Thank you for having me. Really appreciate it.
It's great to have you.